Hello, everybody. We are here at the Dante Pazzanetti transmission to MedStream with great pleasure and privilege. And I would like again to thank everybody at MedStream, specifically our good friend Samir Mehta.
This is a 69-year-old male patient. His clinical presentation, his stable angina, now CCS3, with worsening with his symptoms in the last 3 months. As comorbidities, he has hypertension, dyslipidemia, and a body mass index 19.5. We can see here in the RAO caudal view a very critical and calcified lesion in the proximal LAD. And you can see the red arrows here, the calcification without the dye. In the cranial view, we can also see very heavy calcification. We see a slow flow towards the distal bed of this LAD. Finally, the LV function is well preserved.
So one vessel disease with some collaterals from the right, normal LV function. How do you make your decision?
Once we have a really good collateral, the LV function is preserved. So in the long term, if we let this patient in the medical treatment, I think the LV function will be decreasing.
Would you select this patient for ischemia, or it's eligible for ischemia?
This patient, he doesn't have left main stenosis, significant stenosis, so will be rolled out based on an angio CT or in the angiogram. Symptoms of stable angina. He does have a positive functional test, non-invasive functional test for ischemia. It was not quantified, but it was a positive test, so he will be, yes, eligible for a randomization in the ischemia trial.
Do you think the medical treatment can improve symptoms for this patient? Or is it, I think we need to revascularize to have a better quality of life. This man is 69 years old. He's still in a good shape. So do you think we should revascularize to have a better quality of life in this kind of patient?
Yeah, I think there is always room for optimizing the medical treatment. This patient we are seeing here, his heart rate is about 67. It could be decreased. We can try to optimize to some extent, but the degree of stenosis and the large myocardial at risk, I think will not be, medical treatment will not be enough. This patient will still be limited to some extent, and that would speak for vascularization. Would be PCI with stenting. Due to the degree of calcification, and this is by angio already, we definitely are considering we need some sort of plaque modification strategy because it's a heavily calcified plaque, and as we know, heavily calcified plaques, the chances to have some difficulty in advancing, expanding the lesion, advancing material, deploying stent, and optimize expansions are very high. And to have an undeployed stent could be also a significant predictor for restenosis, for thrombosis, and also acute events. So nowadays there's some dedicated tools such as rotational atherectomy for a long time already, but we have been using more and more in our labs nowadays for complex cases. Laser is another therapy for plaque modification, less used here. And also it's a new tool, not so new, but we are starting in our country to use more, the IVL, intravascular lithotripsy, that we can also have a way to fracture the plaque and then facilitate the stent implantation optimization. Imaging guidance is also very useful to understand this full anatomy and to plan the procedure.
So do you have any preference for these dedicated tools?
They all depend how does that, what's the response as we try.
So, but we should start always with the balloon, or you go direct with a tool like this?
Always with the balloon.
With the balloon
should
first.
Try with the balloon first. Okay, so these are the angios that have been done today. Again, heavily calcified, looks like a deep calcium. Intravascular imaging very useful to understand what the extension of more superficial calcium as well. That's a 7 French guiding catheter.
Why do you use a 7 French guide in this case?
Because when you deal with a lesion like this, it also involves a bifurcation. You have to take into consideration that you might need to use rotational atherectomy. You might need to escalonate. You might need to deal with a bifurcation. So 7 French give you much more flexibility, complex
Do you prefer
situation.
to use femur or radial in a case like this?
I rather to use radial when possible,
Hmm.
but for this patient it was not possible to use his radial, so that's why using femur as well.
Okay, good. So did you get across with the wire? What kind of wire did you use?
So the wire here was just a working horse wire, BMW.
So the guiding catheter is a EBU 3.5?
3.5,
Okay.
EBU 3.5, 7 French.
Okay.
And we think we have optimal support. That's what we need
So it's
when we
an
do a
extra
situation like
backup
this.
guiding catheter.
Extra backup to optimal support.
So in the guide wire,
Yes, a guide wire is a non-polymeric guide wire. It's a
why do you
horse.
choose a non-polymeric guide wire?
Safer.
Safer.
It was easier than expected. It went through relatively easily, and we could deploy in the distal bed of the LED.
What did you find?
So we're starting here the mid portion of the LED. You can already see a diffuse calcification about 90 to 180 degrees. That's no significant compromise at this point.
So about the
In terms of lumen?
three quarters of the artery with calcium.
Exactly. Now we're going to move more towards the proximal segment. We can see a tightened lesion here, about 270 degrees of calcium. We see some speckles here of calcium as well. And it calls the attention that it's mostly superficial calcium, but some deep calcium as well. Here you can see the tightest point. It really embraces the the IVUS catheter, even when you don't see a significant left main disease isolated, it compromises the LED also very frequently.
Great.
You try to pick the space or the area better with at least less than 50% of compromise in terms of plaque burden, but the best lumen area that you can have. So here in the distal portion, what we have in terms of lumen is about 3.3, 3.20. Here is a 360 degrees of calcium.
Yes.
It's not where the minimum area is, but it's a 360 degree of calcium. And this is the type of
It's
situation
a superficial or deep?
that's superficial.
Sure.
And that's the type of situation that you're going to have some difficulty on full expanding the vessel.
Totally agree.
Based on what we saw in the IVUS, and we're able to advance the IVUS, our strategy here would be to first try to pre-dilate this lesion with a non-compliant balloon.
Okay.
It's already a balloon 3.0, which
Okay.
fits to the vessel size, and we're going to see how
So
does
it's a
that behave.
non-compliant balloon. So go ahead with the 3.0, please.
So here, I think we are just in position. Okay, go ahead. And
So you need to be careful with the left main. Are you sure you're not getting the left
yeah,
main?
you can have a small test. So the left main is preserved.
Okay.
We're confident here in the position.
Okay, good.
So you can see, I think that's important.
So
We
what's the pressure you're using now?
12, 12,
12.
12.
So you got a good expansion of the balloon. Is that correct?
Yes.
It is, but it's not a full expansion.
No, it's a good one, I would say.
Go up.
You can go up.
Here's what we achieve with 12 atmospheres. Small angel, please, control.
So you went up to 20 atmospheres.
Yeah, now we're going.
Yeah.
Here we're going to go with a
A
larger
little bit
pressure.
not proximal, I think.
Do you usually check with IVUS after the balloon?
Tex. Yes,
I think it's going to be a good demonstration
Tex.
to see the balloon work
What's
in
it?
this lesion. Now, can you bring the image post dilation, please?
In this type of lesions, you're more likely to have dissections, perforations, so that's why it's good to
Okay.
have controls
Okay, good.
and be careful through all the steps.
You're
So-
starting the pullback now?
I'm just started the pullback now.
Okay, good.
We are in the mid portion of the LED.
Mm-hmm.
So you can see the vessel is already a larger vessel here because we have restored the flow. It's about 4.0 as I mentioned, but 3.5 here you can see. So it's a good opening, definitely. Here you can see the 180 degrees of calcium. I don't see some micro dissections here as you expect. The implanting a stent here in this segment, I think it could be attempted. I think we have had a relatively good response. But there's always a concern about optimal expansion. And we still see some sites of calcification that involves not only the superficial, but more the deeper tissues of the coronary, and that could be a limitation have a full expansion
Yes.
in this proximal LED.
You know what I see the problem, Ricardo? When you don't use a tool, you cannot use later after you deploy the stent. So you can be regret
Yeah.
not using now. Because after you deploy the stent, you cannot get a good expansion. I know you need to prove that's useful. You need to look at the data to have a better expansion using the tool. But if you decide for not using, you cannot use later.
Exactly.
Is that correct?
Exactly. And as most say, you can crack and you can fragment the plaque,
Okay.
you're more likely to advance against
got
the
you.
resistance and have full expansion.
Good explanation.
You want a plaque modification to change the lesion compliance. You have a larger diameter. Next one. And this new tool that we plan to use here is called the Shockwave. It's the IVL system, intravascular lithotripsy. Has a few components, and basically you have some emitters at the distal portion of this balloon catheter that you can have a sound wave pressure will represent going up to 50 atmospheres at the lesion location and provide a cracking fracture of the plaque and promote full better compliance and expansion when deploying stent in these lesions. Next one. And so we're going to call here, this is a semi-compliant balloon, but I would say more compliant than usually what we see. They have available in 2.5, 3.0, 3.5, and 4.0 by 12 millimeters in Brazil. And the recommendation is to go as close as possible to the reference diameter. So we're going to choose here 3.5 by 12, and we're going to show the step-by-step to deploy the stent, and there are multiple cycles and pulls that we're going to do at the lesion site.
So it's going to be
3.5 by 12.
by 12. Okay.
And at the balloon you have these emitters that gives you the sound wave pressure.
It's a normal balloon. We have this, will be locking into the machine, and this we're going to prepare the balloon as same as we prepare our regular balloon.
Okay.
So we are going to make a vacuum here. We have to
So just a regular balloon
preparation.
catheter.
So now you are connect to the machine.
yeah.
Yeah. So Luis is going to connect here to the console.
Now you're going to show. Yeah, great. Okay. Turn the other way. The other way. Yes. Yeah.
Up. Pra cima, pra cima.
Yeah.
Yeah.
Yeah. Okay, great. Thank you. So this is where we did the connection there.
Yeah.
Great.
Now we are going to connect to the console. Sorry.
So we're going to advance here.
So we have to guarantee that we have no air bubbles in the inside of the balloon.
Take the bubbles out.
Just to make sure they don't have any air in the system.
Okay. Can you show the angel now? Just to see the balloon. Okay.
So here, folks, I have the proximal distal markers. We're going to
Okay.
advance here. And you should try to cover here all the lesion segments, starting from distal to proximal, if possible. Okay, so I have position here. Test, please. Okay, so I have to pull back here. Okay. Test. So I think we're good to start here. The emitters, they are more in the proximal part of the balloon. And
So now we're going to inflate the balloon.
we're going to inflate now.
For how long?
Up to 4 atmospheres.
20
And then
seconds.
you're going to press the button here to give the pulses where the energy, the sound wave pressure is being applied.
Can you show here? My hands here. Right. Okay.
So 4 atmospheres.
here.
4
Okay.
atmospheres.
Press.
Hands are here.
So we're applying the
Press
Okay,
ace.
good.
6 at
Now,
6 at
six atmosphere for 10 seconds.
10
Down,
seconds.
down, down.
Down.
So we did that 10 seconds, the application of the shockwave. For how many times?
You can go up to 8 times
Okay.
to give 80 cycles. You don't have to, but that depends on how do you think the plaque is behaving
Okay.
to that.
So this is a 3.5 balloon. You went up to 4 atmospheres.
Yeah.
So you're going to move the balloon, or you're going to keep in the same position?
I'm going to move a little bit more proximal.
And
Test,
we are
please.
going to we are going to do with the 6 atmosphere now.
Okay.
First.
4 atmospheres,
6.
Here.
6.
6 atmospheres.
Great.
The
So
second
your
one?
intention is to do like 4 or 5?
Yes. So where you have the tightest point, the more
Okay.
calcified. So we're going to do it again here.
Okay.
Okay.
Again.
So balloon up 4 atmospheres.
So green. So, but you're using 3.5. At the
I'm
beginning, we
rising-
use a
I'm
3.0
rising
balloon.
to
Is that
6.
correct? Yes.
This is a 3.5.
Yes,
Three
so it's
five.
3.5 now with a 3.0 in
Okay.
the...
Again.
That's it. Balloon
Again,
down.
stop it. Balloon down.
Okay.
Okay, so we did
Is there any
5
sign on there?
overall.
No.
No.
Control angel first, and then bring the IVOS.
Okay.
We still have a. So
So this is a control.
seems to me much better. Yeah.
much more clearly, much better by angel.
Okay. Maybe you can compare after the balloon and now, Louis.
Yeah.
Can you bring after the balloon, and you can show the audience
Here is after the balloon.
after the balloon? Could you stop there,
Yeah,
please?
here.
So now you have the image after the balloon. There is some residual stenosis after a 3.0 balloon. And now we are going to show you, if Louis can do that, after the shockwave balloon inflation. If you look at there, this is the control angel. I see some maybe dissection in the superior part of the artery. There is some small dissection. I would
Alô, segura aqui.
say there is,
Segura aqui.
but the lumen is significantly better.
It's clearly better. It's clearly
Let's
better.
check with IVOS now. So now Ricardo is bringing the IVOS catheter. We start with a balloon in a very calcified lesion in the LAD. We went up to 20 atmospheres, a 3.0 balloon. And after this, we did IVOS, and we saw some just small fractures, but it's still a residual, a significant stenosis residual
Imagine.
significant. And now we did the shockwave balloon, a 3.5, 5 applications of the shockwave, and now we are checking with the IVOS.
So we start
Can
to
you-
pull back.
okay.
We're in the mid portion of the LED. So we have seen calcification throughout the entire segment here.
Okay.
This was not the main focus of the application, but from now on, Fausto, that's where we have applied the shock wave. So I think it's clear to see a larger lumen here at this point.
How about the calcium?
The calcium, we see I see signs
here.
of a much more
it's a fracture,
fracturized
it's a
calcium.
fracture.
And due to the cracking that the system is able to do very effectively. Here's this dissection. You mentioned that you have seen some dissection by angel, and we did see at 2 o'clock. But as you can see, we don't see more that crunch of calcium, altogether compromising the lumen very significantly. Here we come into the proximal part of the vessel, and that's where the left main comes. So it's a totally different appearance.
Okay, exactly. So we could see the dissection by angel. We could see clearly by angel. And
So before, what we have seen here, it's a compromised lumen. We
You don't
see
have
the
the- okay,
calcification
great.
distribution.
Thank you.
Now we see a much more open, and you don't see that calcium more in the superficial part of the vessel. You see all the crack, and that correlates with the expansion of the lumen. Now we come in more towards, you see the side branch wire coming at 3 o'clock. So just to position, that's where we had the tightest point. Okay, next. You see the fracture, the cracking. Okay, so you see the 2 o'clock there. That's a discontinuity there. That's a dissection there. You can see multiple fractures. Multiple fractures. And here we just come to the osteum and the circumflex. So we have to be very careful here to position the stent because there's some disease there as well.
so are you going to deploy the stent exactly in the osteum, or are you going to bring it to the left main?
We want to be just at the osteum.
So what stent are you using now?
So we're using a 3.5
Orcidio. It's Orcidio. It's a
Orcidio?
Yes.
Okay.
or serious stent. This is a very ultra thin platform with biodegradable polymer and sirolimus
By Biotronic.
by Biotronic, and that has shown efficacy in multiple clinical trials in complex lesion subsets. Deploy at low pressure to avoid edge dissection, especially if you have disease there.
So there's
That's
a 3.0 or 3.5 stent.
That's a 3.5.
So 3.5, you need to be careful the distal part of the artery, because I think the artery in the mid portion is a 3.0.
I think we're just fine here.
Yeah.
Let's deploy low pressure. So let's go to
Agree.
Yeah.
I'll agree.
6
Yes,
atmospheres
yes.
first. 6 atmospheres first.
Great position.
That's
All
more
right.
than enough. Okay, down. And then knowing by imaging that the vessel is close to 4.0, but the lumen is about 3.5, we're going to go with the 3.5 balloon
And to pose a
non-comply
leg.
to pose a leg.
Okay, so you deploy the stent at 3.0. Can you bring view to a good result.
And if you didn't have this type of lesion preparation, you'll never be able to achieve a result like this
Yes.
with only 6 atmospheres.
So we still have time to post-dilate and do the final IVLs run, please.
So now it's a 3.5 non-compliant balloon by 20.
I mean, the mechanism, how we can see the result very clear with multiple fractures, better lumen, and now we are going to see a very easy expansion of the stent, and now we are going to do the post-dilatation with a 3.5 balloon. So you can see the position of the balloon exactly inside of the stent. It's very important.
12.